objectives will be the following. If you recall, guys, when we did the cranial nerves examination and the optic nerve, we had 3 points, which we said we will postpone this to later on. Now, this is later on. So today's session will have 3 main objectives. The first and most important one is the ophthalmoscopy or the fundoscopy. Then the visual acuity chart, so how to read the visual acuity chart, how to ask the patient to do it, and how to interpret the results. Now, finally, very interesting, we will just spend 1 or 2 minutes discussing the Ishihara color test, the famous one that we usually do, for example, in driving licensing and the rest. Now, once we discuss these and a brief PowerPoint presentation, then I will send you a link to watch the video of the fundoscopy. We will watch it together. It's around 8 minutes. After that, we will come back to the session and we will do a live demonstration of the fundoscopy, then answer your questions and discuss how could this be appearing in the coming OSCE, inshallah. Okay. So I think we can start now. Okay. So as we said, the objectives will be fundoscopy, visual acuity, and Ishihara test. Now, before I start, I think you already took an anatomy lecture, but just to give you a brief description about the basic anatomy of the eye. Now, you know the eye is composed of 3 layers. The outer layer is called the sclera, which is the hard part that usually, preserves the structure of the eye. Now, the sclera is continuous anteriorly with the cornea, which is the anterior most part of the eye, and it usually in contact with the surroundings or with the exterior. Okay. Next is the second layer will be called the uvea. Now the uvea posteriorly is composed of the choroid, and the choroid is very important because it has the blood vessels which will supply the retina. Okay. Now anteriorly, the choroid is continuous with the iris, which is a muscle. It controls the size of the pupil. Now the pupil, this is the hollow inside the iris. Then posterior to the iris, we have the lens. Okay, and the lens is attached by ciliary bodies, which is anchored to the choroid. So the last one is, or the last layer, of course, is the retina. The retina is the photosensitive area where we have the rods and cones, and this is the area where we perceive light and images, of course. And from the retina, the convergence of the retinal fibers, they will form the optic nerve. Okay, so basically these are the 3 layers of the eye. Now, why are we saying this? Because now when we discuss the direct fundoscopy, we need to know a bit about these structures. So whenever we start any examination or a procedure which needs an equipment, usually we start by identifying or preparing our equipment. Okay? So this is how the fundoscope looks like, and it's exactly just like what we have in our labs. Now, if you look at this device has 3 controllers. So the first one is on and off. So you press on this green button, then you rotate this black, circle, and you will turn it on and off. Now, the second controller is the focus, which is on the side. Now, this focus will actually increase or decrease the clarity of the image, and we will be explaining that later on. And finally, we have something called the filter selector. Okay, now this is in the middle, and it will show you different kind of lights, like a large circle, a small circle, a middle circle, and the rest. We will be doing this and demonstrating this during the live demonstration, inshallah, in a few minutes. So this is our device. What we will do is, if you look at the checklist, now in the checklist, we have, it's divided, the fundoscopy checklist, into 2 major parts. or let's say three. The first one is preparing the equipment and making sure the light and everything is functioning well. Now, the second part, it's called the red reflex. And the third part, it is the examination of the fundus of the eye. Now, the second part, which is the red reflex, we need to know what is the red reflex, okay? So if we look at the red reflex, if we shine a light on a patient's eye, it should look like the one on the left side, okay? Which is having the red color, while the eye on the right side, which is the left eye of the patient, is showing what is known as white reflex. Okay, so what is the red reflex? Why do we care that it's present? Now, first of all, what do you think the red reflex is, guys? Any idea? Like, why do you think when we shine a light, we usually see a red reflex? Yes, blood vessels. Yes, thank you. But Adham, it's not in the retina, it's actually in the choroid. So the retina is actually, it's a vascular organ. So what we see is, yes, the blood supply, which is in the choroid plexus. Okay? Can you see the choroid, which is in red color here in the presentation? It is the second layer, and it has the blood supply. It receives the blood supply from the retinal artery. Then it irrigates or it supplies the retina. Okay? So why do we see a red reflex? Because this is the reflection from the choroid plexus vessels or the choroidal vessels. Now, the other question is why the red reflex sometimes is obliterated or we see a white reflex. Any idea? Like why we, in some patients, and this is of course pathological, we don't see a red reflex. Like, what do you think? Papilledema. Okay, we will discuss this. Option is saying cataract. Okay, thank you. Reduce the blood supply. Thank you. Now, Muhammad, to comment on your point, if it's reduced the blood supply, I would say it will look pale, okay? But it will not reflect a white, it will not cause white reflex. Rather, it would be looking pale, okay? We will discuss these points. Now, just if you think about it, now we said the red reflex is from the choroid plexus or from the choroid vessels. Now, anything that can obstruct the light from the exterior to the choroid plexus will lead to obliteration of the red reflex. Like what? If you look at this light beam, which is in green here, you can see that it's piercing three main structures. The first one is the cornea. Okay. The second one is the lens, and the third one is the vitreous body itself. Okay. So it's piercing these three structures in order to reach the choroid. So if you think of these three structures and what abnormalities could be in each of them, you can actually predict what are the causes of white reflex. So to start with the cornea, sometimes we have what is known as corneal opacities. So these are just opacifications, whitening of the cornea itself. Usually it follows infections, some diseases like trachomatis, okay? So which causes, lacerations in the retina, in the cornea, okay? And this is how it looked like, okay? So can you see there is a white reflex, and this is a case of corneal opacity. Okay? Now the second structure that we have, as we said, is the lens. Now the lens sometimes, Ahmad, what diseases? Now any disease actually that could lead to injury to the cornea, like even trauma patients, trauma to the eye, diseases like trachomatis. I think you will study it, inshallah, during the week. I think with Dr. Nihar, inshallah. So disease like trachomatis, the eyelids will go inside, it will scratch the cornea, leading to corneal lacerations. So basically any disease that irritates or injures the cornea. Okay. Now in the lens, you know that we have the lens is the area where we have the maximum refraction in the eye. Sometimes there is something known as cataract. Now, cataract is actually whitening of the lens. Okay, so this is how it looks like, and usually it's present in elderly people, and and in patients with long-standing diabetes mellitus. So can you see that the cornea here is clear, but if you see within the pupil, so this brown thing is the iris, and in the middle, this is the pupil. Okay. Now behind the pupil there is an opacity. Now this is actually a cataract, which is opacification of the lens itself. Okay. Now the third structure that we have is the vitreous body. Now the vitreous body, it's composed mainly of fluids. So sometimes what arises is some tumors. Okay. Like there is a famous tumor, especially in the pediatrics age group. It's called retinoblastoma. Okay. So this retinoblastoma is a famous or one of the most common, cancers in the pediatrics age group. And if we see a white reflex in a child, then we should suspect that this is retinoblastoma. And Ahmed, what is the vitreous body? It is the structure behind the lens. Okay, so can you see the lens and the attached ciliary bodies? Posterior to the lens, it's called the vitreous body. Okay, it contains the vitreous fluid. Now, just to make it clear for you guys, anything behind the lens is called the posterior segment of the eye. Anything anterior to the lens is called anterior segment. Okay, so the lens divides the eye. The lens and ciliary bodies divides the eye into posterior segment, which is the vitreous body, and anterior segment. Now the anterior segment is further divided into two chambers, which is the anterior chamber between the cornea and the iris, and the posterior chamber between the iris and the lens. Okay, so this might give you a better insight when you study about and try to understand the glaucoma. Okay, so again, let's go back to our case. So this is a case of retinoblastoma. Can you see this child's left eye? And can you see how the white reflex appears on the patient's left eye? And this is actually a fundoscopic view of how a retinoblastoma tumor appears when we get closer with the fundoscope and look at the fundus of the eye. This is how the tumor looks like. Okay, so guys, the red reflex, again, this is shining the light from a distance at the eye. Normally we should see a red reflex because this is the choroidal vessels reflex. This is from the blood vessels in the choroid. If it's obliterated or it's white in color, then we suspect a pathology in the structures that the light is going through, which is namely the cornea, the lens, and the vitreous body. Okay, so this is the first step in the fundoscopic examination. Okay, so first of all, we check the equipment, then we look for the red reflex, then we will approach and the patient's eye until we see this fundoscopic view. Okay, so this is the fundus of the eye. Now, when we look at it, we see that we have the optic disc, which is the most important structure. So the structures we need to pay attention in the eye in the fundoscopic examination is number one, the optic disc, then the blood vessels and retina, and finally the rest of the retina. Okay, no problem, guys. Even if you didn't take the anatomy, what we will have is a very basic, anatomy of the eye, or we need just very basic structures, which we will explain, inshallah. Okay, so the structures and the fundus of the eye, we have the optic disc. As we said earlier, this is the area where the optic nerve emerges into the eye. So the eyeball is actually continuous posteriorly with the optic nerve. Okay. Then in the optic disc, I need you to know two structures. I think we have heard about this before. We heard about cupping of the optic disc yesterday in the PBL case. We heard about papilledema before, like in the week maybe of increase intracranial pressure. We had something like, we said papilledema, and we said we will discuss that later on. So actually these abnormalities are abnormalities in the optic disc. So what is this optic disc? So if we look at it, guys, can you see this circle, the first one? This is the disc margin, okay? So let me put it back. So can you see how clear and demarcated is the margins of the optic disc? It should be very clear and well demarcated. This is the normal finding. Now, in the center of this optic disc, we have what is known as the central cup. Now, this central cup is just a halo in the middle of the disc margin, and it contains the blood vessels. Okay, so can you see the emerging blood vessels, the retinal vein and retinal artery? Then from this area, from the central cup, they will, spread to all the parts of the retina. Okay, guys. So clear now. This is a very basic idea. Now, what is this area in the middle? Again, this is a halo in the middle. It contains the retinal arteries and veins mainly, and other structures. Now, between the central cup and the margins of the disc, okay, can you see this rim? Now, this area is actually the fibers of the optic nerve, okay? So if I remove this, if you see, these are the fibers of the optic nerve. They converge from the retina. Then all of them, they meet at the optic disc, forming the optic nerve. So the optic nerve is simply the nerve endings of the retinal body cells, okay? So this is how a normal optic disc should look like. So it should be well demarcated, okay, with a central cup. This is the outside of the optic disc, okay? These are the margins, okay? So this is the margins of the optic disc. So it should be well demarcated, okay? So it should be really clear. Can you see it here? There is a fine line that demarcates the margins of the optic disc. Now, this is the central cup inside, okay? Can you see this halo and all the blood vessels emerging from this central cup, okay? So this is the central cup. Now, this is the area in between. Can you see this area, this rim? Now, this is in between. This is actually the fibers of the optic nerve. So the retinal fibers, they converge from around the eye. Then they reach this area where they form the optic nerve, okay? Now, usually the central cup is not more than half the diameter of the disc margin, okay? Now, this is normally it should be about 30% or 0.3 to 0.5 maximum, okay? So if it's more than half the size of the optic disc, then that would be called cupping, as we will see in a few seconds. Now, let's take a look at some abnormal findings. Now, what can you say about this image? If I tell you to describe it, just simply. Now, if we compare this one to the original one, the eye-taking point is, can you see the margins of the optic disc here? It's very unclear, okay? Yes, thank you. No clear demarcation, okay? So this is very clear sign, and we can detect it. Of course, even you can see some bleeding around the optic disc. It's very clear that we have bleeding. But apart from the bleeding, we don't have a demarcation or demarcated margins. Now, what do you think the cause of this might be? Why do you think we don't have that clear disc margin? Yes, thank you, Muhammad. Papilledema. Yes, Abdurrahman, thank you so much, guys. So please don't forget that the optic nerve, actually, it has, as other cranial nerves, a meningeal sheath around it. So whenever we have increased intracranial pressure and the CSF pressure will build up, so the optic nerve, it will be compressed, and this will lead to appearing of this picture. So this is the papilledema that we've been talking about since, I think, week 2. Okay, so this is one of the signs that we look for, and if we find it, then it's a window for us that we know we have increased intracranial pressure, And we might decide not to do a lumbar puncture just based on this finding, okay? So the fundus of the eye gives us a good window to the intracranial pressure. So if you take a look at it and if you see that we have obliterated or no demarcated disc margin, then this could be indicative of papilledema. Okay, let's take a look at another case. What can you say about this, guys? So I think the margins are clear of the optic disc. But what is this in the middle? This is the central cup. Do you think its size is normal? Yes, thank you. This is cupping. So what do you mean by cupping? So cupping, and you said no, the size is not normal. Okay, increase in diameter. Okay, guys, so the idea is basic, enlargement of the central cup. Okay, so the central cup, it appears larger simply not because actually it's pushing the rest of the optic disc, but actually if you remember, what did we say about this margin? What is it? It's actually the retinal fibers, so forming the optic disc. So if we have a large central cup, it means that we have less retinal fibers forming the optic disc. So less optic disc, let's say nerve fibers or nerve cells. What does that indicate? It indicates that we have retinal atrophy or death in the retinal, body cells, and hence their axons and nerve endings. Now, this is very famous in the case of glaucoma, as we took yesterday. Okay, so the back pressure from the anterior segment of the eye will push on the posterior segment of the eye, leading to now the pressure in the eye will exceed the pressure in the choroid vessels. Okay, so the retina receives the blood from the choroid. It needs there's a blood pressure inside it. Now, if the intraocular pressure proceeds or exceeds the blood pressure, it will lead to actually necrosis and, of course, ischemia to the retina, and some parts of the retina will start atrophying. Then the more retinal fibers atrophy, the less optic nerve fibers we have, and the more the cup will look enlarged. Okay, so it's not actually, the cup is not per se enlarging, it's not pushing away the rest of the optic disc, it's actually relative. So because the loss of the optic nerve fibers, because of the retinal fibers death, that's why the central cup now looks larger. Okay, and how larger? It's enough for it to be just more than 50%. Yes, to say that this is optic disc cupping. Okay, so please, in this semester, we have two major findings that we need to know about, which is the papilledema, mainly loss of the demarcation of the optic disc, and then finally the cupping, or it's called increased cup to disc ratio. Okay, good. So guys, any question about the optic disc? Now, of course, guys, the optic disc is nasally situated in the retina. Okay, so it's coming from the nasal part of the retina. That's why we will say that later on when we approach the patient, we approach him laterally so that we fall immediately on the optic disc. Okay, طبعا it's the most important structure in the eye. And by the way, any light falling of the optic disc, it's called the blind spot. Okay, and there will be no image forming here, but our brain will try to cover it. Okay, so actually we have a blind spot in our temporal fields, both temporal fields, corresponding to the light which is falling on the optic disc, because the optic disc here, we don't have retinal fibers. There is no retina here. Okay, so I hope the optic disc is clear. This is the first structure that we will look at in the fundoscopic examination. Good. So again, we need to comment on the disc margin, clarity, and on the central cup. These are the two most important points. Now, once we're done with the optic disc, then we will move our light. So this is the optic disc. And you can see that in the central, as we agreed, in the cup, it emerges, the retinal artery emerges and veins. Okay. Clarity, Ahmad. Yes, clarity. So we have the clarity and the clarity of the optic disc, which is the margins, and of course the central cup. Then after we're done with commenting on the central, on the optic disc, we will go to the blood vessels. Now the blood vessels, we have 4 main arcades in the retina, okay? Can you see that the optic disc is nasally situated or medially, okay? So this is medial and this is lateral. And in the eye, we don't say medial and lateral, we say nasal and temporal, okay? So the optic disc is nasally situated, and from it, it emerges 4 main arcades. So we will actually follow each arcades, now dividing the retina into 4 quadrants, okay? Now, what do we need to know about these blood vessels, and what should we like comment on? طبعا usually we comment on if we have any problems like bleeding, of course, if we have any bleeding, if you have new vascularization, but this is for later on, inshallah, in the second semester. What I need you to know now is there is a case, it's mentioned in your checklist, it's called AV nicking. And what does that mean? Now, usually, can you see that here in this picture, for example, we have this artery and maybe we have this vein, and they usually cross, okay? So arteries and veins, they usually cross. So can you see here, there's a crossing, but it appears normal. Sometimes in patients with hypertensive retinopathy, what will happen is the artery will nick the vein. This is how it would look like, because there is high blood pressure in the artery, so it will actually obstruct the vein. And this is clinically how it looks like. So can you see this is the artery, okay? And this is the vein. And the artery actually is obstructing completely the vein because of the high blood pressure. And this, of course, will lead to venous engorgement and maybe later rupture of the veins, leading to bleeding in the eye or in the retina, okay? So AV nicking is a sign of hypertensive retinopathy, okay? This is as for the blood vessels. Then, of course, we inspect the rest of the retina, okay? Now, what should we inspect the retina for? Just for if we have any abnormalities, any pigments. I think this will be explained better in the video as they have more clear images. So we just follow the blood vessels, the 4 main quadrants. We comment if we have any abnormalities in the blood vessels. Then we comment over the rest of the retina if we can see any abnormalities, any bleeding, any abnormal pigments, okay? Or maybe abnormal findings like the retinoblastoma I showed you earlier, okay? Now, the last structure that we need to examine is, can you see this fovea? So we have this area, which is called the macula, and its central fovea. Now, the macula, if you can appreciate, it's a bit darker than the rest of the retina. So this is an area where it is a bit darker. So can you see it's yellowish here, and here it's more of, let's say, brown to red, okay? And at the center, we have the fovea. Now, why should we pay attention to that? Because the macula and fovea is the site of maximum visual acuity, okay? And it's very important because if the patient loses the retinal fibers here, the patient almost loses his vision in this eye, okay? Because this is the site where we have the most concentration of rods and cones, okay? And this is the site of maximum visual acuity. So how do we inspect it? Simply, we ask the patient to look at the light source, but we do that at the very end of the examination, okay? So once the patient is looking at the light source, then we know that now we're inspecting the macula and fovea, okay? Now, this is the basic, theory part about the fundoscopic examination. So we have preparing the equipment, then the red reflex, then we approach the patient until we see the fundoscopic view. Once we see it, then we have to look for 4 structures: optic disc, then the vessels, blood vessels, the retina, and finally the macula and the fovea. Okay, so don't worry about this because this will be explained fully in the video, which I will send you the link in a few minutes. Then finally, we will again demonstrate it. Okay, and inshallah you will be practicing this in 2 weeks, so don't worry. Yani we will repeat it more and more. Okay. Now the second objective of this session is the visual acuity chart. Now, guys, I think we have touched on this in yesterday's um, PBL case. Now I want us to know how to interpret the visual acuity chart and how to do it, how to interpret it, how to give the patients this number that we had like in yesterday's case. So any idea, guys, what is this chart called? I think all of us, we have seen this chart before. So this is called Snellen chart. Okay. So this is called Snellen chart, and in the clinical skill labs, maybe you haven't seen it before, but it's actually, we have it there. Okay. So inshallah, when you come, we will do this test, clinically. Now, of course, the visual acuity chart or the Snellen chart, it has either letters like this one, but we usually prefer to use directions like arrows, because some patients, if they're illiterate or they don't know, for example, the English alphabet, this test will be invalid. So usually we prefer to use the arrow ones. But regardless of that, let's see how should we, interpret this. So what do you think these numbers indicate? So what is this 6/60, 6/36? And which one is the best one? Which one is the normal? And why 6 here is fixed? And what is this changing number on the right side or on the denominator? Any idea, guys? Anyone can tell us? If you know, like, you can open your mic and just explain to your colleagues. Okay, 6 is the distance where the patient is standing from. Okay, good. Do you agree, guys, with your colleague? And Ahmed, how about the other one? What about the 60? So what is 6/60 here? So what is the second number? Okay, good. Thank you, Ahmed. So can you guys understand what your colleague said? So simply, when we have this chart, we will ask the patient to stand 6 meters away from the chart. Okay, that's why you can see that the denominator is fixed. It's always 6 over something, 6/24/18. So meaning that, how do we interpret this? So if you say 6/24, it means that what normal people can see from 24 meters, our patient can see it from only 6 meters. Okay. So the first number is how far can our patient see this number from, which is fixed because the patient is standing 6 meters away from the chart. The second number, this is the number where normal people could see this line from. This is pertaining to the line, of course. Okay. So if you say again 6/9, meaning that what normal people can appreciate from 9 meters, our patient can see from 6 meters. Okay. So the more we go up, the more the denominator number increases, the less visual acuity of the patient. So for example, here 6/60. So this big T, a normal individual with normal visual acuity, could see it from 60 meters away. Okay. But our patient only can see it from 6 meters. Okay. So you can see how severe his visual acuity is. Okay. So clear, guys, what do these numbers indicate? Now, the problem is things are not that straight and easy usually. Now, let's say, what if your patient could read, can you see this fifth line, which has HUWOX? Now, what if our patient couldn't see the X, for example, but he did the rest correct? What can we say? What is his visual acuity? So he read the first 4 lines, and the fifth one, he said HUOWO, and he couldn't appreciate the X. What can we say about his visual acuity? Still 6/9. Okay, but actually he couldn't read anything from the 6/9 or 6/12. Okay. And how about the X that he missed? What if he misses like the O and X? Can we still say this is 6 over 12? And is he equal to someone who can read the full line? This is what you mean? He has two possible mistakes. Okay. Now, simply, guys, what we will do is if the patient misses up to 3 letters or 3 signs in the same line, we would say 6 over 12 minus 1. Okay. Yes, it's not half a point, so we will subtract. Okay, so we will write 6 over 12 minus 1. Okay, if he couldn't appreciate the X, for example. If he couldn't appreciate the X and O, 6 over 12 minus 2. If he couldn't appreciate up to 3 letters, we can still give him the mark of this line, but minus. Okay, so if he misses the W, O, and X, we would say this is 6 over 12 minus 3. Then what if the patient could read only the H here? What would be the patient's visual acuity? If he could appreciate from this line only the H, so only one letter, and he missed the other 4. What can we say? Yes, thank you, Hajar. Okay, so we will go back to the weaker one or to the previous one. So we would say his visual acuity, yes, is 6 over 18 plus 1. Okay, guys? So up to 3 letters, we will subtract. So we will give him the patient the same visual acuity of the same line, but we will subtract. Okay, so for example, 6 over 9 minus 1, minus 2, minus 3. But we don't say minus 4. If it's minus 4, then we would say 6 over 12 plus 2. Okay, so up to 3 letters, if he misses from the same line, we would give him the visual acuity of the same line, but minus. If more than 3, he misses more than 3 letters, then we would go back to the previous one, then add what he could appreciate from the next one. Okay, guys, is this... No, Abshina, I mean, the subtract, we can only take up to 3, okay? So, for example, look at this, 6 over 6. If the patient couldn't appreciate only the A, so this is 6 over 6 minus 1. W and A, 6 over 6 minus 2. IWA, 6 over 6 minus 3. If more, we will go back, so his visual acuity will be 6 over 9 plus, مثلا, 1 or 2 or whatever he could appreciate from the below line. Okay, guys? So this is basically how can we interpret the patient's visual acuity. Now, let's say that your patient couldn't appreciate the big T at the top here. What would his visual acuity be? Zero. Okay, so what would 0 indicate? You mean he's blind, Yani? Okay, then what can we say? Like if he couldn't see the big T from 6 meters. Hi guys, any suggestion? Now Nada is suggesting that move 1 meter, decrease the distance. Yes. So guys, simply what we will do is, no, the patient is not appreciating the big T from 6 meters. So simply we will ask him to approach. Ahmad, 6 over 60 minus 1. Actually, this is a good suggestion, by the way, but we need like to know, maybe this patient is blind, he couldn't see anything, okay? So we need to make sure that what is the patient's visual acuity, okay? So simply we will ask him to approach 1 meter. So now he was 6 meters away. Now he is 5 meters away from the chart. Maybe at 5 meters, he could appreciate it, okay? So if the patient appreciates this big T from 5 meters away, what would be his visual acuity? Any idea, guys? So we ask the patient to approach 1 meter to look at the big T, and then he could see it. He tells you, yes, I can see a T letter. Yes, thank you, guys. Thank you so much. It's 5 over 60. So now I think you get the idea, okay? So the 5 is the distance from our patient to the visual chart, and then the 60 is fixed because it's fixed for this big T. Now this big T, normal people could see it from 60 meters. So this is fixed, okay? But actually we have asked our patient to approach 1 meter. So good. So it would be 5/60. What if he couldn't appreciate it? Again, approach 1 meter more, okay? So this would be 4/60 until the patient reaches 1 meter away from the chart, okay? If he could see it, again, the visual acuity will be 1/60. Now, if our patient couldn't appreciate the big T or the largest, line in our visual chart from 1 meter of the chart, 1 meter away, what could we say about his visual acuity? 0/60. 1. Bushra, of 1 if he can see it, but he couldn't see it. Even from 1 meter, he couldn't see it. And 0, what do you mean? Like 0, yani 0 here, it means what? What is 0? Yani 0 here meaning the distance. Okay, Jassim, we will come to this. Now, if you say 0, it means that يعني انه يعني حط وجهه بالchart. Okay, ask him to count your fingers. Okay. Okay, guys. So if our patient couldn't appreciate from 1 meter away the big T, there is no point of asking him to approach even more because 1 meter is very close to the eye chart. Okay. So simply what we will do is we will ask the patient to count the fingers. Okay. So we will ask him, you will, with your hand, you will make, for example, 2 or 3 and ask him, how much is this? Or can you tell me how many fingers can you see? If the patient, again, couldn't see it, then we will wave our hands in front of the patient. Then if the patient couldn't even appreciate the hand movement, we will shine a light at the patient's eye. And this is our last resort. If the patient couldn't appreciate just the light shining, then this patient is blind. Okay, guys? So this is how we approach the worst, visual acuities. So 6/60 couldn't appreciate it. Approach 1 meter at a time. At 1 meter, he couldn't appreciate it. Then finger counting, then hand movement, then finally shine a light. If he couldn't, appreciate any of these, then this patient is completely blind in this eye. Okay, guys? So, but this is, of course, for your own knowledge. Okay, what do we report? Like we report the patient's visual acuity. He is responsive, for example, to hand motion or to counting fingers or to shining light. Okay, so it will not be a number anymore, but actually we would say that his visual acuity, he is, responsive to this. Yes, thank you, Khadija. This is a good question about the distance. Now, it would be just like the patient is standing and you're standing in front of him, okay? Just like the normal distance, let's say 0.5 meter, okay? So not very far away, yani no more than 1 meter. Yani the patient is looking at the chart, he's now 1 meter away from the chart, and then you will just stand between the patient and the chart, okay? So there is no actually specific distance, but it should be less than 1 meter, okay? Because 1 meter he couldn't see, so it should be less than that, okay? So this is simply the visual acuity. But again, what I need you to understand is the numbers, what do they mean, and how do we interpret them? And in the exam, if you have, for example, any visual chart like this, and I tell you this patient can appreciate 1, 2, 3, 4, what is his visual acuity, then you would be able to answer that, okay? Now, just one point, guys. Sometimes we can find it in 20/20 or 20/200, like we see in this visual chart. Please don't get confused. This is simply the meter system and the feet system, okay? So don't get confused about this. It's exactly the same thing. It's just like 2 different measurement systems, okay? So if you were asked about the metric or the feet system, it would be exactly the same idea, just like we did it right now. Of course, we use here the metric system, but if anywhere somebody tells you that your eye vision is 20/20, so you know that, again, what it means. So it's the same thing, but in feet. Okay. Okay, guys. Now, the last objective that we have in this session is the Ishihara color test. And I think all of us, or the ones who did a driving license test, we did this test, and it's actually a book. Inshallah, we will show it to you when you come to the college. It's a book that you simply have such, images and photos, and you're asked to report what can you see. Okay. So, for example, what can you see in this image? Can you see a number, or you can't see anything? Okay, guys, so you can see number 8. So simply when we go to the interpretation in the Ishihara colors test, we see that normal patients or normal individuals, let's say here, they could appreciate the number 8, while red-green deficiency or patients with red-green deficiency could see another number entirely. Okay, it's so interesting that they could see number 3 here. Okay. And it's very important because in the driving license, why? Because this red-green deficiency is crucial, and in the traffic lights. That's why they usually do it, and before we take our driving license. Okay, so let's take another example. What can you see in this image? Can you see a number? Anything? Okay, so just colors, no numbers. So yes, you're correct. So normal individuals should report saying no numbers, nothing. But patients with red-green deficiency, actually, they should see number 2. Okay. Now, how about this one? This is the last one. Yes, thank you. Now, by the way, guys, this is, I think, usually the last page in the chart, and everyone here should see and must see number 12. So if anybody is, trying to maybe fake color eye blindness, you can catch him from this number. So if he tells you, I can't see anything, no, everybody here, even patients with any different color, blindness, they must appreciate the number 12. Okay, so usually this is done, maybe this is usually the last slide and the color box and the Ishihara color system. Okay, so it's really interesting. You will be having the manual with the color book. Then when you ask your patient to say what he can see, you can see the reference and what normal people could see and what a patients with different color discrepancies and blindness could see. Okay, it's very simple. Don't expect this to appear in the exams. It's very easy. This is for your own knowledge. It's interesting. Yani, inshallah, when you come, you can see it in the Ishihara's colors test. Okay, guys. So by now.